Uh, I mean, I would love for people to be interactive if possible. So I will just, يعني, I'm wondering whether someone could really quick, like analyze this ECG for me, if possible.
Est-ce qu'il y a quelqu'un qui veut participer à analyser cet ECG? Il peut parler anglais, français, arabic, no problem.
Yeah. يعني it's an easy one. Don't be shy. سهلة. Okay, so maybe people are still shy. So as you can see, oh, there are people are typing. Okay, so I do see tachycardia junctionale, I guess, and ABNRT. Okay, so definitely the patient is tachycardic. Her heart rate is around maybe 180 beats per minute. The patient is resting in clinic or in the emergency room, so there is no explanation for him to be this fast. When you encounter tachycardia, this is how you should think through it. Okay, so the patient, first of all, you analyze the heart rate. The heart rate is tachycardia or tachycardic. Then immediately you ask the question: is it narrow complex tachycardia or wide complex tachycardia? Obviously, in this case, the QRS is nice and narrow, and then you have only two main differential, or like, I mean, to simplify things, either it's sinus tachycardia or supraventricular tachycardia. And then in order to differentiate between both, you want to study the P wave, okay? So you look at P waves, you hunt for P waves. If you don't see P waves that are obvious, or if the P waves are not seen or are abnormal in axis, then this is SVT. If you see P waves that are normal in axis, that are monomorphic, then you can be suspicious of sinus tachycardia. But otherwise, if again difficult to see P waves, polymorphic P waves, abnormal axis P waves, then this is an SVT. What do I mean by a normal axis P wave? So that's an example of another patient, 14 years old with leukemia, who was febrile. So with a heart rate of, again, 150 or around 150 or 140 or so. Okay. So here in this case, it's a narrow complex tachycardia, but if you can obviously see P waves. Okay, that is upright in lead 1 and V6, for example, and upright in lead 2, 3, and AVF. Okay, so why is this important? Because if you remember, the sinus node is in the right atrium, so the average atrial depolarization is going this way, meaning from right to left and from superior to inferior. Okay, so the left leads being 1 and V6. The atrial depolarization is heading towards lead 1 and V6, hence the P wave is positive. And 2,3 AVF being inferior leads, the depolarization is heading towards the inferior aspect of the heart. The P wave would be positive in 2,3 AVF. So if you see P waves that are positive in lead 1, lead 2, lead 3, lead AVF, this is sinus, most likely a sinus P wave. And if the patient is tachycardic, this is most likely sinus tachycardia, especially if the patient is febrile, is crying, is irritable, is sick, is hypotensive, is running, etc. The sinus rate usually is 220 minus the patient age. It's secondary to something, something, and it's usually fluctuating in rate. There is a gradual increase in heart rate at the onset and gradual decrease at the term, offset, with 1-to-1 PQRS ratio. So is this does do am I making sense? Do you guys understand me? Any questions?
If you want, I can comment
Yeah, yeah, sure.
in French. Ici, il parle de tachycardie sinusale Il vous dit que si vous avez des ondes P positives en D1, D2, D3, AVF et V6, c'est très évocateur d'une tachycardie sinusale et surtout, parce qu'on peut avoir tachycardie atriale parasinusale, comment faire la différence? C'est quand on a une accélération progressive ou ralentissement progressif. C'est-à-dire que la tachycardie sinusale, elle n'est pas stable dans le temps. C'est pas comme les tachycardies pathologiques, c'est-à-dire qu'elle est variable. Et bien sûr, c'est les causes, la fièvre, l'anémie, toute pathologie comme cet enfant de 14 ans qui a eu leucémie. Yes, Dr. Mohammad, you can continue.
Okay. Okay. So you can see clear contrast between the initial ECG, which was also tachycardia without P waves, hence SVT, versus tachycardia with preceded by P waves that are normal in origin, hence sinus tachycardia in a patient who's febrile, anyways. Okay, so back to my algorithm or to the algorithm. So this patient had tachycardia, narrow complex, and now we know it's SVT because we cannot see clear P waves. And then furthermore, then you ask yourself, is it regular or is it irregular? Okay. طبعا in this case, it's, regular. Okay. So now we diagnose a patient with narrow complex regular tachycardia that is not sinus. So this is SVT in short. Okay. This is how you should diagnose the patient having a form of SVT. Okay. Then you ask yourself, is the patient stable or unstable? Okay. طبعا most likely 99% of the times the patient would be stable. Okay. Very unlikely for an SVT patient who's young, healthy to present in an unstable state. Okay. So the patient obviously was stable. So then if the patient's stable, you want to treat with vagal maneuvers, adenosine administration, or rapid atrial pacing if you have the ability, okay? And then you want to do ECG recording during your maneuvers. If the patient is unstable, you want to shock the patient, okay? I understand in Algeria there's no adenosine, right, Dr. Wafa?
Yes, there is no adenosine, yes.
Yeah, which is unfortunate because adenosine is very, very important and very nice agent that we use routinely, okay? But inshallah, it will be coming to Algeria, and then you would be able to use it in the future. But nevertheless, you need to know about adenosine regardless. Okay, um, so with vagal maneuvers, if the patient is very young, usually you can do ice, immersion, gastric tube insertion, older patient, any Valsalva maneuver or headstand. With adenosine, it's usually given IV through a large IV access with a big flush. And I prefer to administer adenosine in good dose, at least 0.15 to 0.2 per kilo. And then if I don't see effect, I maximize the dose to be sure of the effect of adenosine, okay, before calling it non-responsive to adenosine, okay? But you should not give adenosine in irregular rhythms in general, okay? I will not talk about adenosine so much because I know in Algeria you don't have it, but inshallah it's coming. But the good thing about doing vagal or adenosine, it could be diagnostic, meaning, for example, this is a patient, an infant or a newborn presented with this ECG. As you can see, it's a narrow complex regular tachycardia. The P waves are not very well seen. Um, um, not well seen. For example, here, you don't know, is there, where is exactly the P wave? And if so, is it positive? Is it flat? If you look at AVR, you don't see like very clear P waves. If you look at AVL, so, I mean, I don't have the entire leads, but anyways, you're suspicious of SVT, of course. So you do vagal or you do adenosine. In this case, we gave adenosine because it's easier. And then when you give adenosine, what do you see after the adenosine, guys? I will try to give chance for people to respond?
Est-ce qu'il y a quelqu'un qui veut répondre? Ils ont donné, donc ça c'est un nourrisson et était rapide. Et après, on voit le ralentissement. Donc il y a quelqu'un, there is someone,
Yeah,
you will flutter, at their flutter, yes, good.
yeah, good. So many people did appreciate there's flutterways underneath. So the adenosine or the vagal maneuver could unmask your flutterways. Okay. So then now we know the patient was having atrial flutter. Okay. Plus another case, narrow complex tachycardia, most likely supraventricular tachycardia. You give adenosine or do vagal maneuver, and then the tachycardia terminated. Okay. So there is sudden termination of the tachycardia, and then there's a little bit of activity before normalization of the ECG. So in this case, it was therapeutic measure. Okay. So this is an example of, this is not my ECG. This is a patient of Dr. Said, who's a friend of mine in Saudi Arabia, patient presenting with narrow complex tachycardia. Again, the P waves are probably negative, not normal looking. There is, well, not negative, sorry. You might think it's negative, but in retrospect, it's probably the P waves are here, retrograde here. But anyways, it's not sinus tachycardia. We think it's more likely SVT. The patient was having atrial, wire. So they rapidly paced the atria, and the patient, the ECG changed to normal sinus rhythm. Okay, so that's an example of atrial pacing of an SVT terminating the SVT. Okay, I don't think you have this, Dr. Wafa, in Algeria, right? Like you have transesophageal wires or a pacing lead or.
Yes, we don't have transesophageal. Yes, we don't have.
Okay. Okay. But if the patient is post-operative, usually there are wires that you could use, or the patient have intrinsic pacemaker. Okay. طبعا if the patient is unstable, the rare event that the patient is unstable, طبعا like we said, we can shock the patient. Shockable rhythms are usually reentrant rhythms that characterized by sudden onset and termination, and they are largely regular. For example, flutter, AVRT, AVNRT, okay? And in addition to atrial fibrillation is also shockable, of course. But we don't see atrial fibrillation in pediatrics, so I don't think you'll be seeing much atrial fibrillation in pediatrics. And then if you want to shock the patient, I usually try to place the pads anterior, posterior, like in this cartoon, like right anterior, left posterior, left posterior for atrial flutter, and then regular positioning for any other form of SVT. Okay. So, positioning of the pads might be important sometimes. Okay. Okay. So now we are talking about SVTs but specifically regular narrow complex form of SVT. So like we said, we always try vagal or adenosine when it's regular. Okay. Often it terminates, but sometimes after termination, it reinitiates. That's why you want to do ECG during the adenosine or vagal maneuver, because we want to see that termination plus reinitiation. Often people call us, we did vagal or we gave adenosine, but nothing happens. But in reality, something happens. It terminated, but then resumed like soon afterwards. Okay, so if this was the case, we know it's a reentrant rhythm of some sort, like AVNRT, AVRT, and but it's coming back. So you want to give the medication. You guys hear me, right? Sorry, I don't know why I became unmuted. Okay, muted, sorry. So if this is the case, I usually give IV medications. So if the function we do quick, I recommend doing quick echo. If the function is depressed, I prefer AMI or plus minus digoxin IV. If the function is good, I prefer esmolol. Okay, you guys have amiodarone, right? Wafa?
Yes, we have amiodarone, yes,
Yeah,
and esmolol
you do,
since
right?
1 year, yes, yes. But
Okay.
in our country, all patients amiodarone. I don't know why. I think esmolol is better if we have good LV function.
Yeah. So like Dr. Wafa was saying, if the function is good, just start with esmolol. If the function, I'm worried about the function, I might prefer amiodarone, okay? طبعا sometimes, but I usually prefer IV medication if the patient if the patient keeps having SVT after your IV, your adenosine or vagal maneuver, okay? طبعا you can do IV plus oral, but oral agent. But I think IV agent is very important in this scenario. Okay, so like we had seen sometimes with adenosine or vagal, you might uncover flutter waves. If the patient is having flutter, then you have to, if the patient is newborn, you usually cardiovert, and then there is no need for long-term therapy. Okay, so that's it. Newborn, flutter, you cardivert. Often there's no need for anything else in terms of long-term therapy. But if the patient is not newborn, more than newborn, usually flutter is not it's not gonna go away by itself. Usually there is cardiomyopathy, congenital heart disease, something that resulted in flutter for this patient, and ablation or medications are required. Okay. Obviously, you want to rule out thrombi or prior to any cardioversion if the flutter is prolonged, and then you want to assess risk for anticoagulation administration. Okay, and you want to assess risk factors and to figure out whether the patient deserves any anticoagulation long term or not. Okay, so. So for flutter newborn, it's usually transient, you cardiovert, and that's it. Okay. طبعا if there is no response for sure with adenosine with vagal maneuvers, then it might be another diagnosis, technique is wrong, you should probably consult an experienced electrophysiologist. Okay. Okay, so we talked about amiodarone. These are the what I typically do. طبعا people do it differently. I if I want to bolus, I try to avoid bolusing in newborns, especially preemies. Okay, there is a risk of cardiovascular collapse with bolusing a newborn or especially preemie newborn. So I usually start with an infusion. Okay, sorry, infusion. Okay, but if the patient is not newborn, I may bolus and then I do 2.5 or 5 per kilo slowly. Okay, roughly over 20 minutes or so. Okay. And the infusion is around 5 to 15 microgram per kilo per minute. Okay. I don't know what you guys do, Dr. Wafa. Do you guys usually do the same or differently?
Yes, it's different. Me, it's like say now, but in some pediatrics, it's used not per kilo, but in surface body,
Yeah.
meter carry.
Okay. Okay.
Yes.
Okay. طبعا with amiodarone we prefer central lines. Okay. You can, I don't know, do you guys have verapamil, Dr. Wafa?
No,
IV?
we don't have verapamil.
You don't have. Okay. And then Asmonol you do have. So Asmonol could be given central or peripheral. It's a rapid acting agent. I usually do, I give 100, but then like in 2, 3 minutes, nothing, patient is okay. I will immediately go up to 200 microgram per kilo per minute, at least. Okay. So then stay at between 200 to 300 microgram per kilo per minute infusion. Okay. طبعا you can go higher up to 400, but usually, this is the typical range for Esmolol effect. Okay. Um, I don't know, Dr. Wafa, do you do the same?
Yes, I give one dose and then if there is no response, I repeat after 5 minutes or 10 minutes. Yes.
Okay. Okay. So I do infusion of Esmolol. Okay. And then you have IV digoxin or you don't have, Dr. Wafa?
Yes, we have digoxin, yes.
Okay. So طبعا IV digoxin could be given central or peripheral. طبعا dosing digoxin is complicated because it depends on the patient age, prematurity, so forth. So probably best to look it up as you encounter patients. But طبعا in general, usually you load with 10 mics per kilo for people who are less than 10 years of age. But then second and third loads are Q8s are usually like 5 per kilo. Okay. طبعا maintenance is around 5 mics per kilo. Q12 again for less than 10. Okay. For more than 10, usually the dose is less. Okay. And then, but طبعا you have levels that you can do and guide you further. Okay. But digoxin dosage is a little bit complicated. Okay. طبعا there's also IV flecainide and IV sotalol. But it's not widely available. We do have IV flecainide in Kuwait, but we don't use for that often. And I know that in the US and Europe, they do have IV sotalol. I don't think you guys have any, right, Dr. Wafa?
Yes, we have only a small amiodarone and digoxin.
Okay, okay. Okay. طبعا once you give IV drug, you try then to once, I mean, in my practice, I usually do IV, like we said, if there is frequent SVT not terminating with adenosine or not staying in sinus after adenosine. And then if the patient is able to eat or drink, then I start oral and overlap the oral medicine with the IV medicine um, so that I can quickly stop the IV medicine so that the patient is more, like we can discharge the patient sooner. طبعا I don't usually give any oral agent if the patient, for example, is not eating or because of the concern for GI not absorbing the medicine. Okay. Especially if there's decreased perfusion, especially in babies. We try to give initially IV, like we said, and then if once the patient is able to tolerate feeds, then we start oral agents. Okay. Okay. So, but most patients would actually terminate with adenosine and vagal and remain in sinus. Then I admit the patient if the patient is unable to communicate non-verbal. Okay. But if the patient is able to recognize he's in SVT, he came with with that complaint, we can start oral medications and discharge, but mainly oral beta blockers and discharge with education or for the family. Okay. طبعا if it's a baby or neonate, I treat for typically 4 to 6 months. Some people extend therapy up to 12 months. Okay. But usually we stop and then reassess. And if there's no recurrence of SVT, we discharge the baby. Okay. So it's not often long-term therapy. Okay. This is what you guys do, Dr. Wafa, probably.
Yes, I talk about this in the last webinar. It's
Okay.
only for 20 months or 18, 18 شهر.
Okay.
And then we
Yeah.
stop and we see.
Okay. So I do stop it much sooner. يعني 6 months, usually I'm already weaning. Okay. And for the most part, babies don't, have recurrences. Okay. If the SVT started after 1 year of age, then the SVT would come back, and then patient needs long, chronic therapy, or طبعا ablation is an option. Daily medications. Some people might elect to take a medicine, like not to take medicine except as needed. Pill in the pocket, for example, propranolol. Like, for example, they're doing well. They have SVT. They know how to recognize SVT. They take their propranolol, do Valsalva for 20, 30 minutes. If it's not stopping, then they can drive to the hospital. Okay. Or some people choose not to get any therapy, and then they do Valsalva. And if it's not stopping, they go to the immediate ER next to them. In Kuwait, the country is small, so there is roughly 20 minutes hospital, like everywhere. Okay. طبعا if the patient has WPW, then usually we prefer ablation. But if there's no WPW, we can, we don't have to, patients might not want to do ablation, which is fine. Okay. And then we offer ablation for 15 kilograms and above. Okay. طبعا you have to remember calcium channel blockers are contraindicated in infants, and digoxin and calcium channel blockers are also contraindicated in WPW patients. Okay. And like I said, some people might say, don't treat until after the second episode. I do treat even after the first episode, especially if the patient is nonverbal, like he's 1 or 2 years old or 3 years old. I treat and I don't wait for second episode. Okay. Or at least I offer treatment and not wait for another episode. Okay. Because it will come back. Okay. Makes sense, guys? I will stop here شوية for questions.
Yes, sorry here, Dr. Mohammad Ebrahim. I don't
Yeah.
understand one thing. Maybe we can speak Arabic. For me, neonates يعني less than 1 year، أقل من واحد، يعني SVT in infants أقل من 1 year، رضيع أقل من سنة. I stopped the medication at 12 شهر أو 18 شهر. But in children يعني فوق السنة if we have SVT we must continue treatment. It's
Yes, this is what I said. صح.
okay.
Yeah. But I said neonate, you give 4 to 6 months. Okay. So shorter than 12 months, but it's okay. Some people give 12 months. But after 1 year, I usually I don't stop unless we do ablation. يعني more chronic therapy. صح?
Yes.
Same thing, right? Okay. Okay.
And for ablation in France and in guidelines, if we have children with VPV syndrome and he is stable with medication أقل من 5 سنوات, we don't do ablation, or like you said أقل من 15 كيلو just antiarrhythmic treatment. But after 5 years, if the patient is stable, so medication, there is no SVT, no palpitations, يعني متى you must do EP study and ablation to assess the risk of sudden cardiac death. In France, all accessory pathways must EP study أقل من 10 سنوات. And what do you think?
Yeah, so I offer ablation above 15 kilograms. I don't care about the age, usually about weight. طبعا in Kuwait at least 15 kilograms is usually 3 years and above. Okay. Not 5, يعني 3.5 years, maybe 4 years and above. Okay. طبعا once they are at this weight, I start talking about ablation for WPW patients. Okay. Sometimes I try to do risk assessment, meaning I do Holter or stress test, and if I see convincingly that there is loss of WPW beat to beat with elevated heart rate, then this might mean the patient is at lower risk for sudden cardiac death or arrest. But this is very rarely seen. It's sometimes very difficult to be sure of this loss of pre-excitation. So I tell the families, I try to get rid of all accessory pathways, or what I suggest to them, unless it's super duper clear that there is weak characteristics of the accessory pathway, and then I tell them it's probably very weak, but I still would suggest EP study. Okay. So I try to push for EP study because there are case reports of people with weak accessory pathways, but presenting with sudden cardiac arrest. So I always try to push for ablation, طبعا regardless. But usually I wait for 15 kilograms. Okay?
Yes, okay. And then
Okay.
for in يعني عند الأدلت الناس
Hmm.
الكبار there is contraindication of beta blockers and digoxin and but in children I see in the new guidelines 2024 in United States American Heart Association there is no contraindication
Yeah.
we can
I do give beta blockers to my WW patient all the time.
no.
No problem. There is no contraindication. I try to avoid DIG and calcium channel blockers, digoxin and calcium channel blockers, which I don't even routinely use anyways. But I usually do beta blockers or flecainide. Flecainide is a very good agent for WW. طبعا if there is WW and the patient is not wanting ablation for whatever reason, I usually do beta blockers or flecainide. These are my two main drugs. طبعا flecainide is very good agent, okay, for WW patients. You have flecainide in Algeria?
Yes per os يعني oral or not
Oral,
injected.
yeah. Yeah, of course. Yeah, us too. Okay, so for the oral, we do, طبعا, like we said, mainly beta blockers for most SVT forms. طبعا, the in general rule for beta blockers, you can go as high as tolerated. But طبعا, with propranolol, I usually stop at around 4 to 5 milligram per kilo per day. Okay, divided Q6 for less than 4 months, Q8 for more than 4 months. So I usually give propranolol for babies because they are often awake and requiring to feed frequently, so it's not a big deal for the families. But obviously, if the patient is sleeping all night, above 1 year of age or so, I then switch to atenolol. Okay. طبعا we do have metoprolol or bisoprolol, but I don't routinely use in pediatrics. Okay. Which beta blockers do you have, Dr. Wafa?
We have all this, yes.
All this. Okay. 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 Um, but I imagine you guys do mostly atenolol and propranolol, I imagine. طبعا we have also nadolol, but I use for long KT something else, not for SVTs. Okay? Okay. So for amiodarone, I don't rarely do oral amiodarone. I don't like it. I try to avoid it as much as you can, but these are the dosages. But again, I don't think I have, probably I have one patient on amiodarone oral, that's it. I mean, I don't use it at all. I do IV a little bit, but oral chronic, I don't do. Okay. And then oral digoxin, these are the dosages, and ivabradine is usually more for atrial tachycardia or sinus tachycardia. And I'm trying to delete this atrial tachycardia or sinus tachycardia. Okay, I don't know how do I delete this. Okay, anyways, okay. So questions about the dosages?
Ivabradine more than 6 months, yes?
Yeah. I mean, I think I have given it less than 6 months, but like I think it's FDA. If you want to go by the FDA rules, it should be more than 6 months. But but I don't use it for SVT. I use it for atrial tachycardia.
Yes.
Okay. Okay. Um, Flecainide I use often for especially WW patients or atrial arrhythmias. This is my typical dose. I usually stop at 5, not 6, 2 to 5 milligram per kilo per day. Okay, طبعا some people use per meter squared. I don't. I usually do by kilo. And then I do Q12 less than 4 months, 4 months to 8 years Q8, and then more than 8 years Q12. Okay, there are levels, but we don't have them in Kuwait. I usually monitor ECG, usually after 1 hour after the dose, for at least 2 to 3 days. Make sure the QR is not widening during flecainide. Okay, and then it's renally eliminated, so you want to make sure. There are comments that are in. Okay, so Dr. Ofa, you're responding. Okay, good. And then you want to adjust if there's renal disease. Okay, Sotalol is usually 2 to 4 milligrams per kilo per day, Q8 for less than 12, Q12 for more than 12. Okay, and then with total you monitor the QT interval. Okay. طبعا oral verapamil, I usually use it rarely. I use it for specific type of ventricular tachycardia, but for SVT, I rarely use it. Okay. Once in a while, I do have patients that on verapamil for SVT, but I rarely use verapamil. Okay. Um, and these are the dosages. Okay. Obviously, when you are giving, beta blockers are usually benignish, but flecainide, sotalol, these are heavy pro-arrhythmic agents, so you want to make sure someone with experience is monitoring the patient. Okay. Okay. So so this is another case, a 4 years old patient with palpitations. Again, as you can see, there is a tachycardia, maybe 180, 190 beats per minute. The tachycardia is narrow, complex. And then thereafter, you want to ask yourself, is it sinus tachycardia or is it supraventricular tachycardia? Again, you look at the P wave. You see lead 1. Do you see clear-cut P waves? You don't. You look at lead 2, okay? You see probably P waves that are negative, okay? Look at AVF. So you see P waves that are negative. So it's not sinus tachycardia, because with sinus tachycardia, you want the P waves to be positive, okay? So this is an SVT, okay? So why is this an important ECG? Because we can classify SVTs further into short RP interval versus long RP interval. So in short, if you look at the QRS, okay, if the QRS, if you see P way beyond the QRS, like in this case, this is called long RP. In general, more than 2 small squares, this is called long RP, and then the long RP tachycardia are usually more difficult to treat. So that's why when you recognize a patient with long RP tachycardia, you might want to give oral agents, combination of oral agents, like a couple of ones all together same time, because these patients are usually difficult to treat with one single agent. So usually you want to give good doses, combination, and you want to use high potent drugs like flecainide, and so forth. Okay, so that's why it's important to recognize type of SVT. Is it short RP, easier to manage? Long RP, more difficult to manage. Okay. Okay, so when I came to Kuwait, I tried to create a protocol, which I briefly already mentioned. So like we said, if you have a regular narrow complex tachycardia with 1-to-1 P to QRS, mostly it's a stable rhythm, and then you do adenosine or vagal, and then if it's short RP, you just give propranolol or beta blockers, and usually you're good. If it's long RP, I usually try to start flecainide quicker. Okay, maybe I start even the first line. Okay, so this is a little bit of distinction. And unstable, like we said, we cardiovert. Okay, so we talked about regular SVTs now. For irregular SVTs, it's more usually your main differential in pediatrics is atrial arrhythmias, atrial tachycardia. Okay, they are typically more difficult to treat, and then often or sometimes associated with cardiomyopathy, or they can induce cardiomyopathy because they are more incessant, more difficult to treat, sometimes slower, so the patient don't recognize that he or she is having irregular or fast heartbeats. Okay, this is one example of a patient. As you can see, there is a narrow complex tachycardia here. Okay, and like if you look carefully, this interval here is longer than this interval, so definitely irregular. Okay, and then it terminates, and then this is sorry, and then this is a P wave, and then tachycardia resumes. Okay, so that's an example of an atrial tachycardia. Um, and then another irregular SVT is AFib, atrial fibrillation, which is very rare in pediatrics and might be associated with hypertrophic cardiomyopathy, for example, or other cardiomyopathies. Okay. Okay. Quick question. Any questions about irregular SVTs? So same management, except that these are probably more difficult to treat. Okay. And then for AFib, of course, you want to like flutter. You want to make sure you might want to give anticoagulation for the patient. Okay. Okay. Questions, guys? We're approaching the end here. So this is, I think, our last case. So this is a more difficult case. So 8 years old, the patient presented with pale, very ill-looking palpitations, chest pain, and the heart is almost above 350. Okay. So what do you guys think of this ECG really quick?
Est-ce qu'il y a quelqu'un qui veut participer? Pour être simple, est-ce que la tachycardie, est-ce qu'elle est rapide? La fréquence, première des choses. Le QRS, est-ce qu'il est large ou fin? Et est-ce que c'est régulier?
Pardon, je vais répondre. Je vais essayer de répondre.
Oui, docteur.
La fréquence, elle est,
Oui, oui.
la fréquence, elle est rapide. Le QRS, par contre, il n'est pas, il est large.
Très bien.
Et je pense que c'est régulier quand même, non? Un petit peu,
C'est irrégulier également.
irrégulier.
Oui, oui.
D'accord.
Comment qu'il est rapide,
Ouais.
mais quand même il est irrégulier, oui. Très bien. Le
Ok.
QRS, il est large, avec, bien sûr, avec le rythme, il est rapide et c'est tachycardie à QRS large, là, hein. Donc, c'est clair.
Ouais, ouais, ouais.
So I heard probably wide complex tachycardia, right? Large meaning wide complex, right?
Quite very quick, yes, and irregular.
Yeah, excellent. So I mean, mashallah, people here are very smart.
Yes.
So irregular, wide complex, polymorphic looking, and very rapid. Okay. Okay. So when you see such an, yeah, I mean, he's only 8 years old. This is a patient of mine, only 8 years old. Obviously, still not fainting, but sick looking. So the patient is more towards being unstable. So yeah, I mean, typically when you see such irregular polymorphic white complex tachycardia, most likely you cannot do adenosine, for example, because irregular, like we said, you don't give adenosine for any irregular rhythm. It's contraindicated. So you have to shock the patient. طبعا, if you have an experienced electrophysiologist, might give IV procainamide, IV, I don't know whether you have IV procainamide, Dr. Wafa. We don't have, for example, in Kuwait.
We don't have
You
it.
do? Yeah. But in general, most people would cardiovert such rhythms, and then we'll see the ECG post cardioversion. But your differential should include pre-excited atrial fibrillation, and I think someone had mentioned this. So in this is how I think of wide complex tachycardias. طبعا wide complex tachycardias could be irregular. In this case, it's irregular. So طبعا VT, polymorph VT, VF is obviously your main differential, especially in adults. Okay, best in pediatrics. It could be irregular atrial tachycardia with aberrant conduction or QRS aberrancy, variable, aberrancy, or like in this case, or it could be atrial fibrillation. Obviously, it's irregular with a patient with intrinsic WPW, such that the QRS is changing from beat to beat depending on how much the conduction going down the accessory pathway versus how much the conduction is going down the AV node. Okay, so when you have any polymorphic, irregular, wide complex tachycardia, these are your main three differential. Okay, طبعا in pediatrics you want to think about this. You want to think about this differential mainly. So this patient, طبعا in this case irregular, and you can see the onset is slurred. It's like a big delta wave, the onset of the tachycardia. Okay, anyways, this patient did not have, has a normal structural heart, and there's no family history of like channelopathies or anything. So AFib with WW was highly on the list, sorry. And really quick, for regular tachycardias that are wide, this is how you should think of it, of your SVT in adults especially, but antidromic SVT or SVT with aberrancy is another differential. So not every wide complex tachycardia is VT. There are SVT differential for wide complex tachycardias. Okay. Anyways, so this patient, while in the ER, she vomited, felt sick, she vomited, and then suddenly the ECG changed to this ECG, okay, without cardioversion, okay? So what do you guys think this ECG is showing?
Est-ce qu'il y a quelqu'un qui veut interpréter? Dr Mohammad.
Ben, le rythme ne paraît pas rapide, hein.
Oui, oui, maintenant,
Ouais.
on voit, il est en sinusale, on voit l'onde P, elle est là, d'accord, en D2
Oui,
positive, mais il y a quelque chose de particulier quand même.
il
On
y a
voit pas
quelque chose de
l'espace
particulier.
PR, on voit pas le PR, il est très court, avec une onde
Oui,
d'air,
oui, oui, oui.
d'accord? C'est un Wolf Parkinson.
Ça va, oui,
Okay.
les dents des plats, ouais.
Yeah. Yeah, so I mean, I think I'm hearing WPW. So there is, as you can see, short PR, delta wave, okay? For example, here. So the patient was, in retrospect, the patient was having AFib, atrial fibrillation, and we know that patients with WPW are at higher risk for developing atrial fibrillation compared to the general public. Okay, so once in a while you encounter a patient who's very young, like in this case, 8 years old, with almost a rhythm that almost might kill the patient. Okay, and as you can see, as in this case. Okay, so for that specific people, those specific people, the pre-excited atrial fibrillation, it's rare but life-threatening, and it might happen to at 1 or 2% over the lifetime of a patient with WPW. Okay, so these patients really need to be ablated prior to discharge. Okay, because they did show that they are able to conduct this fast, and as such, they are at risk of death, like sudden death. Okay, so usually we admit and ablate at the same admission. طبعا, let's say you cannot ablate for whatever reason, your flecainide is your drug of choice. Okay. But in general, like we said, WW, in general, we always try to ablate the patient, especially if there's no obvious very low risk characteristics. And in this case, we actually ablated the patient. As you can see, the QRS changes from pre-excited to non-pre-excited during RF ablation. Okay. Anyways, so in conclusion, always try to record ECG during vagal or adenosine, administration, so that we see exactly what happens during your intervention. Okay, because like we said, very often you see transient change that you might not recognize, like on the spot. Okay, and you want to really, document that. Okay. There's a question that we'll come back to it. I tend to give adenosine. I know you guys don't have adenosine, but you can do vagal, I guess. But I usually give adenosine to all regular narrow complex, and often I also give adenosine for regular wide complex rhythms for diagnostic or therapeutic purposes. Okay. طبعا, unless I do believe that this wide complex is VT because of other features like AV dissociation, access to suggestive ventricular tachycardia, and so forth. But if I'm not so sure, I give a test dose of adenosine. Okay, and wide complex rhythms could still be SVT. Okay, adenosine is contraindicated in irregular white complex rhythms. And such irregular white complex rhythms are usually complex, and experts should be involved. Okay. And WW might present with life-threatening arrhythmias, or the patient might be at risk of life-threatening arrhythmia, and hence ablation is often recommended. And then in general, you want to have an algorithm in your mind how to differentiate between different SVTs, and how to narrow your differential so that you appropriately treat the patients, or so that you're able to appropriately treat the patient. Okay. And I think there's a question in the chat that we addressed already. So like we said, asymptomatic WPW, if the patient is 10 years of age, like in this question, I usually tell the family that there is still risk of sudden cardiac death, despite the risk stratification that we can do, whether in stress test or Holter. And I try to push for ablation. But if there is, especially if with stress test and Holter, I don't see any beat-to-beat loss of pre-excitation. If there is clear-cut, super weak accessory pathway, I am less pushy for ablation, but I tell the family that there is, despite that low risk characteristics, when the patient is exercising or irritable or has high catecholamine, that risk characteristic might change and the patient might be at risk. So in general, I try to ablate most of WW patients. Okay, and then we offer ablation at 15 kilograms and above. Okay. طبعا if we think the accessory pathway is parahesian, we might wait for him to grow older, like maybe 25 kilograms. But in general, otherwise, just 15 kilograms is good enough. Okay. Okay. So I think, Dr. Wafa, I'm done. I don't know. I hope this was helpful. I mean, my French is weak. I did not speak much Arabic because I wasn't sure whether I will be also understood. Inshallah, my English was not that complicated.
No, it's very good and very practical, and I hope useful to change our practice in Algeria. As you said, we must avoid amiodarone for preventing SVT, but
Yeah.
the best choice medication is beta blocker, propranolol, for example.
So, yeah.
And I don't know if you have a question. Maybe we
I
have
have
5 minutes.
I have a question. So adenosine, you think it's expensive? Why is it not available in Algeria? I don't,
I
I
don't
mean,
know, but I talk with some people who can decide in our country, and I think inshallah it will be available soon, inshallah.
because
But
I'm guessing
no,
it's
why?
not
I don't know
expensive.
why.
Yeah.
Yes, I don't know. And I have, if you have question, we have only 5 minutes. And for me, I have one question. If you have
Yeah.
flutter, neonate flutter, uh,
Yeah.
do systematically anticoagulation or how you proceed? For me, I don't do. I don't know.
Yeah.
Yeah.
No, I mean, obviously, most people will, if there is no congenital heart disease, if the patient has a complex heart disease, then you might obviously lean towards yes. But normal heart or uncomplicated heart disease, like for example, just a stupid small ASD or something, and the CHADS VASC score would be very low, and usually the patient will not meet any risk scoring for anticoagulation. طبعا babies, like we said, we cardiovert and خلاص, it's like almost end of story. But beyond, like in neonatal age, there is usually a reason for atrial flutter to happen. Like, is it Epstein? Is it complex heart disease? Is it cardiomyopathy? Something. Otherwise, it's very unusual to have atrial flutter outside the neonatal period. I do have a patient with severe sinus node disease, like very severe, like very bradycardic, and gets tachybrady, like flutter and sinus bradycardia episodes, that we ablated when she was only 9 kilograms, because you cannot give her beta blockers or salt low or anything, because if she's outside flutter, she's slow. Even during flutter, her heart rate is slow. Like during flutter, a baby, like 1 year old, heart rate is like 110, you know? So the AV node is not great. The sinus node is not great. So it was difficult to treat her with medication. So we ablated her when she was only 9 kilograms. But otherwise, it's very unusual to see flutter outside the neonatal period. I don't know. Do you see flutters in Algeria commonly, not in babies?
No, no, in neonates, and I
Oh,
think I see some infants, 6 months, 9 months. I think there is no diagnostic in the يعني مش مشخصين في
yeah.
I see
Mm.
one children 9 months with تأخر في التطور في النمو.
Yeah.
Yes,
Yeah.
and
Yeah.
هو كان في الكارديوميوباثي عمل arrhythmic cardiomyopathy, and after
Mm.
cardioversion normal heart, normal evolution. Yes,
After cardio يعني التطور صار طبيعي.
yes, exactly, yeah.
ما شاء الله, interesting. طبعا, yeah, sometimes يعني usually sometimes you see patients that might fail to thrive after يعني improving your rhythm, the growth improves. But يعني this is unusual. بس عموما, yes, I don't do anticoagulation. Even for that patient, she did not require anticoagulation. طبعا, except you do TE or echo before cardioverting just to make sure يعني. But in general, they don't require chronic anticoagulation.
Yes. Okay.
Yeah. Okay. انتوا يعني دكتورة وفاء, you do this meeting every month ولا how often ولا it's random?
No, no, I start because I want to learn people to how treat SVT and arrhythmia in general. But if you if you propose, we have people who want to learn, no problem. And
Yeah.
thank you very, very much for you. I
Welcome. So just there's a quick question by Mehdi. I think he meant, can you do EP study in 7 kilogram babies? You can. I mean, there are people who do EP study for newborns, but only if you have to, only rare cases. It's possible. Okay.
Yes.
Okay. Um, but my youngest is 9 kilograms. But I know, for, other people, they did like 4 kilograms, 5 kilograms babies. It's doable.
Yes, when we have resistant SVT or
Yeah.
yes,
Right.
BPV, but it's rare, yeah, it's rare.
Yeah.
Okay,
Okay.
thank you so much. Thank you, Dr. Mohammed. Thank you.
Welcome. Thank you.
Thank you.
Thank you.
Au revoir.
شكرا. مع السلامة.
مع
مع
السلامة.
السلامة.
مع السلامة.